I'm going to introduce. All right. Good morning, SLO families and other attendees. My name is Kate Duran, and I serve on the board of the Smith-Lemli-Opitz Foundation as the Director of Communications and Family Outreach. It's my honor to introduce Dr. Elias this morning. Dr. Ellen Elias has been working as a pediatrician for more than 40 years, specializing in caring for children with developmental disabilities and medical complexities. She's the medical director of the Special Care Clinic at Children's Hospital, Colorado. Dr. Elias is an expert in treating children with underlying genetic problems, developmental delay, feeding issues, and birth defects. She cares for patients with Smith-Lemli-Opitz Syndrome, chromosome abnormalities such as Down syndrome, and autism. A graduate of Princeton University and New York University School of Medicine, Dr. Elias is an international expert on Smith-Lemli-Opitz Syndrome. We're lucky that she has spent so many decades researching our syndrome, and I'm honored to welcome her to this forum this morning. Parents and caregivers, I present to you Dr. Ellen Elias.
Hi, good morning, everybody. Thank you for that very, very kind introduction. So what I'm going to do is I'm going to share my screen. I put together just a few slides of some of the main issues I wanted to cover this morning, but mostly I'd like to try to address your questions. And when Gretchen Noah first reached out to me and asked me about this topic, I felt like there were so many answers or possible answers that it was just maybe more helpful to address it this way. So I'm going to try to share my screen and go from the beginning. Let's see. Oh, can you see it? Okay, great. I see nodding heads. So today, the main topic of conversation is my child has Smith-Lemli-Opitz syndrome. Is it safe to return to school? And in Kate's kind introduction, she said who I am and where I trained and what I do. So the Special Care Clinic is a unique program in Colorado at Children's Hospital, Colorado, where we provide care to more than 5,000 children with medical complexity, underlying genetic disorders of all different kinds. And the question of the hour for every single one of all of the patients that I see every single day is, what should I do? And can my kid go back to school? So I just wanted to talk for a second about what we know currently about the COVID-19 pandemic, and with the caveat that this is a very fast-moving target, and the information that I'm giving you today is based on all of the updated information that I get a slew of every day. I get information from the American Academy of Pediatrics, from the CDC, from my own hospital infectious disease group, which also culls information from all of the groups around the country. I was part of a team of doctors from all over the country that met twice a month throughout the pandemic to talk about how do we help our families who have children with complicated medical problems, and what have we learned, and what are the best recommendations. So I think about this topic quite a bit. Currently the main version of COVID-19, which is going around, not just in the US, but abroad as well, is called the Delta variant. It was originally started in India and then very, very rapidly spread everywhere throughout the whole planet. The Delta variant has differences from the original Alpha variant that we saw starting in 2020. First of all, it's extremely contagious. It's much more contagious than the original variants of COVID were. And so if you, I was trying to learn about this just over the past couple of days, but if you have COVID-19 and you're around other people, it has this ratio of spreading it very quickly to 7 other people all around you are going to get it from you, unlike influenza, which is more like 2 or 3 other people. So it's extremely contagious. The other really different thing about this Delta variant is that children are more likely to get this variant and show symptoms from it. So the original Alpha variant, which some people are still basing their decisions on from what things looked like a year ago, were that kids were fine, they were protected, they weren't going to get sick, don't worry. And that is very different now with this Delta variant. Pediatric hospitals all around the country are being filled with very sick children who have the Delta variant of COVID. And these children are not only sick enough to be hospitalized, but they're sick enough to need intensive care. And so what pediatric hospitals have seen now is this huge upsurge of children who are not protected and are definitely vulnerable to getting the Delta variant. And this is different from the prior variants that we saw last year. And what we clearly know about this Delta variant are that people who are most vulnerable to it are people who are not protected and have not yet been vaccinated. And so when you look at at the 100,000 new patients all across the country that there are of this Delta variant, that was this morning's number, the vast majority of those people, almost 100% of people who are sick enough with the Delta variant to either need to be hospitalized, need to be in intensive care, or who die from this, are people who are not vaccinated. There are 2 main versions of the vaccine that have been developed and made by the Pfizer and Moderna companies. The Pfizer vaccine is given in 2 doses, which are 3 weeks apart, and the Moderna is given in 2 doses, which are 4 weeks apart. There are mild side effects that people can get from these vaccines more often after the second vaccine than after the first one. Some people get nothing. And then other people have things like low-grade fever, muscle aches, pretty sore arm. Here in my hospital, everybody got Pfizer, and after the second vaccine, we were instructed to just kind of hang out and not maybe work the next day after you got it if you could, and just kind of sort of be a slug on the couch. But then by the day after that, you could go back to work and we're fine. And that was the experience for most of the people who got Pfizer. There were some people who got the Moderna form who got a little bit more symptoms after the second dose. But again, the side effects to the vaccine are fairly short-lived in the vast majority of people. There are some people who had, 2 or 3 days of fever and muscle aches and felt really crummy, but for the most part, it was not so bad. There is a huge amount of incorrect information that's being passed around on social media, news outlets, some of them, and so on, about reasons why you should not get the COVID vaccine. And I wanted to sort of take away some of those myths and fears that people have. First, the biggest one that I've heard most often is that people want to wait and see, and this vaccine is too new, it was just developed, we don't know enough about it. It's true that we don't know everything about the vaccine. For example, we don't know if we're all going to need boosters next year or not. But it's not true that it was just invented over this past year. In fact, this technology has been around for quite some time. It was invented many years ago for other viruses, something called MERS, which is Mid-Eastern Respiratory Virus, which never turned into a major pandemic, fortunately. But the technology was there, and so it was easily adapted to COVID, which was a fairly miraculous thing. But I've heard all kinds of things. I've heard that it makes you infertile. So I've had a lot of young moms, young women who are afraid to get it because they're worried they're not going to be able to have children. That is not true. Some people are worried that a microchip is going to be inserted into your arm and then the government is going to follow everything you do. That is not true. There's just a lot of misinformation out there trying to convince people to not get the vaccine. My recommendation is there are some people who it's not safe to get it because they're very allergic to ingredients in the vaccine and things like that. But talk to your physician and make sure that your physician is comfortable with you getting vaccinated if you have not yet been vaccinated. And then my plea to all of my parents who have not yet been vaccinated is this is the only way, the only way that you can really protect your children. So there's been a lot in the news that about this Delta variant. And does the vaccine protect you from not getting COVID? Unlike earlier versions of COVID, which the vaccine protected you from getting sick at all, you can get the Delta variant even though you've been fully vaccinated. And we've seen now hundreds and hundreds and hundreds of cases of that. But if you are vaccinated and you get the Delta variant, by and large, you are not sick enough to need to be in the hospital or in the ICU or die from COVID. And I have seen young, healthy parents who are not vaccinated die from COVID, from this Delta variant. It's a really, really bad player. So you may get a little bit sick with the Delta variant, even though you're fully vaccinated. So think twice about going to that big restaurant, going to that big family reunion, that big wedding without a mask, because being fully vaccinated is no longer totally protecting you from COVID. Which is why the CDC came out within the past week saying, reversing what they had originally said, which is if you have the vaccine, you're totally safe, throw the masks away. Now, with the new information that's available about how contagious this is and the fact that there can be breakthrough infections, even if you're fully vaccinated, they're talking about you'd be safer to wear masks in indoor spaces. And you can still spread COVID, even if you're fully vaccinated. If you get sick, you have enough viruses in your body to spread it to other people who might not be vaccinated. And those people might need to be in the hospital or in the ICU or die. So the recommendation for wearing masks is back because of that, especially in indoor spaces. So what does that mean? What does that mean about being able to safely send your kids back to school? Because depending on where you live, school may be starting next week. That's what's happening here in Colorado, or it might be starting the end of August or September. So what are the questions and what are the concerns that people are worried about with this Delta variant just being so incredibly scary, even to all of us in the medical field who are fully vaccinated and thought we were safe, but we're not quite anymore. But but what do you have to think about and worry about? And what are the safety risks for sending any child back to school? Because children can get sick with this now. They can spread it to their siblings. They can spread it to their parents and grandparents. And once kids are back in school in small confined indoor spaces, what is that going to mean? And we're all, I have to say, all of us in pediatrics from all around the country, we are just very worried. So lots of questions, and the school systems are dealing with this on in very different ways, very individualized depending on where you live. So some school systems, like for example, Denver Public Schools, which is the largest school system in the state of Colorado, have mandated that teachers need to be vaccinated and all staff need to be vaccinated, but not every school system is doing that. What about all the other kids in your child's class? What are their parents vaccinated, even if you are? Will that child be able to wear a mask all day long in school? That is super, super difficult for children to be able to wear a mask all day. Some kids with respiratory disease, they just can't do it. They can't breathe. They really can't. Kids with developmental issues just are not able to keep a mask on all day long. And so what does that mean for the safety of all the other people around them in the classroom? So what about children who have Smith-Lemli-Opitz? Are they more vulnerable to COVID? And are they more vulnerable to the Delta variant? And what about them makes me worried and makes it difficult to give an easy answer about, is it safe for kids with SLO to go back to school? Well, if the child has a more severe form of SLO and the cholesterol level is super low, in the sort of 40 or less range in my mind, I think about that, then there may not be enough cholesterol for the body to be able to make other chemicals that the body needs. And one of the important ones is cortisol. So normally when a person gets sick, your body has lots and lots of defenses against illness. One of them is cortisol made by your adrenal glands, which when you get, when you have a big illness with a really high fever, or you have, or you're having some big surgery, your body will ordinarily make huge amounts of cortisol to help fight the stress. And if you have severe SLO and your cholesterol is very low, you might not be able to mount that normal cortisol response. And so we consider those patients to have what we call adrenal insufficiency. And some of my patients with SLO have prescriptions for getting stress doses of cortisol if they're going in for surgery or if they get sick and have a fever. And so I worry COVID is associated with a fever. And if you get really sick with it, you can have a high fever for many days. And so one of the points I wanted to make is if your child has very severe disease, you should try to think about whether, and talk to your local physician about whether stress steroids might be needed. Fortunately, one of the things we learned about COVID is that giving steroids seems to help. So they might get steroids anyway, but they might definitely need them if they have severe SLO. Some of my patients with SLO, not all, but some of them do have significant cardiac malformations and have significant pulmonary disease. I have some patients who have needed to be trached. And when they get just a regular virus with respiratory illness, they can be sick enough to be in the hospital or get pneumonia. And that's fairly common in my patients with SLO. And so this is one of the worst respiratory viruses that we've ever seen. It's probably worse than the flu, worse than other respiratory viruses that target the lungs or the heart. And so if your child has one of those underlying conditions that makes them more vulnerable to respiratory disease in general, then definitely you do not want your kid to get this Delta variant of COVID-19. And so there are some of my patients that I've had this talk with families about, you know what, it's really, really risky for your kid to go back to school right now. And that is trying to balance this with the fact that doing school remotely for a child who has cognitive disabilities and maybe autism is extremely challenging. And for many, many of my patients, last year was just a total wash in terms of academic services, and very difficult in terms of challenging behaviors for a kid who can't go out and is staying at home all the time. And I get that. I'm desperate for all of my patients to be able to go back to school, because that's where they're going to get services and they're going to learn. But I'm just trying to balance the risk of what would happen if that specific child gets COVID. Because we did see COVID deaths in my special needs patients last year. And that was even pre-Delta variant. So COVID can be a bad player in kids who are very, very vulnerable. So last year in Colorado, the first child who died in our hospital from COVID was one of the patients who is seen in my clinic who had a heart transplant and was on immunosuppressive meds. I've had Smith-Lemli-Opitz patients who have had a heart transplant on immunosuppressive meds. It's again, I can't answer this question for every specific patient because how vulnerable each child is different. But there are definitely some risks in this specific population that worry me. The other thing that I ask about when I'm talking to my families is who else is at home and who else is vulnerable at home. So a lot of my patients live as families that have grandparents who are living with them. And even though the grandparents may be vaccinated, they're not totally safe anymore and can still get sick. And if the grandparent has, a lot of medical problems that go along with being an older person, they may get, if the child brings COVID home from school, that grandparent could get sick. And then a lot of my parents, the age that is most vulnerable right now that we're seeing are people in their 20s and 30s and 40s. That's the vast majority of people in the hospital now, mostly unvaccinated people. And so the age of most of my parents, you can get sick enough to be super, super ill. And really be bad. And then there are all those long haulers, they're called, people who get COVID and don't completely recover and have symptoms for months afterwards: fatigue, severe pulmonary disease and bad asthma, terrible headaches, sort of brain fog, not being able to think right or do the jobs that they used to be able to do. So if you're a parent taking care of, a kid who has a lot of special needs and you get sick and then you become one of those long haulers like that, are you going to be able to do your job to take care of your family? And then everybody is asking me, what on earth should they do about the healthy, normal siblings of their patients with SLO? And, for everybody last year, schools were closed. Everybody was closed. Nobody could go to school. And so everybody was sort of in the same boat, and schools made plans and ways to help kids who could learn online remotely get at least some kind of benefit from learning that way. but everybody is desperate to go back. And for the healthy, normal siblings, is it fair? Is it okay if they go to school and they get COVID from their classmates and they bring it home to their vulnerable sibling or to anybody else who's living at home? And can they bring the virus home? Absolutely. This is incredibly contagious. Are they okay if they wear masks all day long and if they're vaccinated? Well, that's safer, absolutely safer. But depending on where you live and what your school district has mandated, a lot of places are not mandating mask wearing, and a lot of school systems are not mandating vaccination for teachers and staff. And so depending on where your kid goes to school, may be safer or less safe with all of those variables. And again, you know, the CDC made a big turnaround, and with more information coming in about how contagious this is, they went back to recommending mask wearing indoors. And so a lot of people are like, well, I don't know what to do. And if I'm a school administrator, who do I listen to? Who do I believe? You know, they seem to be changing their minds all the time. And what's real and what's the truth? And I think that part of the hard part of this is that we're all trying to understand the science and follow the data and everything, but new information just keeps coming all the time, which makes it really hard to know. Everybody wants their kid to be safe, wants their kid to learn, wants the siblings to have a more normal life. Everybody wants to go back to pre-COVID days. And we can't safely do that at the moment. Will things change? Maybe. I mean, maybe this bad Delta variant things will sort of slow down like they did for the prior variants. But I don't know, because last year we shut down everything. And this year we're not doing that. And this is a way more contagious virus than last year's version was. So it's so hard to predict what is going to happen over the next few months as kids go back to school. As I say to a lot of my parents, I dropped my crystal ball about 40 some odd years ago, and I can't predict the future anymore. So I'm going to stop sharing my screen so that I can see all your nice faces and see if what questions people have had. So the first question I see is, what is the news about when younger kids are going to be able to be vaccinated? So that's a really good question. I talk about with all my patients every day also. We were hoping and had been initially told that by September, we'd be able to vaccinate people 5 years of age and older. But that has changed as of 2 weeks ago, when the FDA requested about 3,000 more children be enrolled in the safety trials before they approve the vaccine for kids 5 and up. So it's going to take time to enroll 3,000 more children and then to analyze that data. So realistically thinking, maybe there will be a vaccination for kids 5 and up, maybe early 2022. That's my best guess. We don't know. We don't know. If you're vaccinated, do you transfer that protection to others? No. It's your body making immunity. And what those 2 vaccines, the Pfizer and the Moderna, what they're telling your body to do is to build immunity against a protein called the spike protein, which is on the surface of the virus. and allows the virus to get into a human cell and infect it. And if the spike protein is blocked, then the virus doesn't easily get into your cells and cause infection. That's how these Pfizer and Moderna vaccines work. And so that immunity that your body is making is not something you can pass on to somebody else. If you get the Delta variant, can you get it again? And does your body build immunity to it, especially for those who are vaccinated? That's an excellent question. So yes, your body does build immunity against the Delta variant, and you shouldn't be able to get that variant again very easily. One of the questions is, how good is the immunity you get from the illness? Is it as good as the immunity you get from the vaccine? And how long does it last? And those are all awesome questions that we don't have the definite answers to. What we saw from the initial 3 variants prior to Delta is that there was immunity that you got to those viruses, but it wasn't lasting. It did not last as long as the immunity you got from the vaccine itself seems to last. The big question is, and we do not know, how long is that immunity really going to last? And are we all going to need to get booster shots next year like we do every year for influenza? With influenza, it's different. It's a different technology for that vaccine. And they decide like 2 or 3 years before which virus strains they're going to put in the quadrivalent flu vaccine. The flu vaccine protects you against 4 different viruses, both influenza A and B. And they decide 3 years before what strains are going around and build the vaccine, which takes that long to make, based on information from 2 or 3 years ago. So if a new virus comes along, like what happened in 2008 with the swine flu, remember that swine flu? That was a new variant of influenza that was not protected against by the vaccine that we were giving that year. And that's why so many people got influenza that year and died from it. Is that going to happen with COVID? Well, the longer it takes to get more people vaccinated and the more people get sick and spread it, that's how viruses mutate. And so the more people we can get vaccinated and decrease the number and decrease the spread of the virus, the slower it will mutate. Will it mutate? Of course it will. It already has mutated 4 times in the past, less than a year and a half. And it will still keep doing that. But what we can only hope is that the newer strains down the road will not be as virulent as the Delta strain, and that we'll be able to modify the vaccines to deal with any changes that come up that we need to make the vaccine protect against you for. So how reliable are the COVID tests is the next question. There are many different kinds of COVID tests, okay? There are some you can like go to some test in a box on the street, and those are not necessarily so reliable. The tests that we do, in a big medical center like mine and so on, are very, very reliable. But what they're not testing for is which variant it is. That's a special test that's not being done with the routine, nasal swab that you do to see if you have COVID. So that is a special test that is like done in different labs around the country, and which is how we know that the Delta variant is as prevalent as it is. If there's a vaccine trial around, is it safe for your child with Smith-Lemli-Opitz to participate? I don't know the answer to that question because it will depend on how the trial is defined in your area. Here in my hospital, They were limiting the trial at first only to healthy children with no underlying medical problems. So it's not clear to me that they would enroll a child with an underlying genetic diagnosis. That may have changed with the new request for more patients, but before, last year, it was not possible. Are masks effective in preventing transmission in the classroom setting? They help enormously in two ways. They protect the person who's wearing the mask from other people who might be spewing virus. And they protect the person who's wearing the mask from spreading anything else that might be contagious, because right now we are seeing other viruses. So normally in the winter, we see a bunch of respiratory viruses that land kids in the hospital. Last winter, we didn't see any of them. We didn't have a flu epidemic last year. We didn't have RSV. We didn't have paraflu. We didn't have any of those nasty respiratory viruses last year. Why? Because everybody was staying at home and wearing a mask and being careful. So we are seeing them now, okay? Right now, there's a big epidemic all across the country of RSV and paraflu. And so adults are getting, and children are going to the hospital and getting really severe respiratory viruses that are not COVID. So masks protect against the spread of those things too. Should kids get the booster shot for COVID along with the immunocompromised population? It has not been determined yet who, if anybody, is going to need a booster. We think people with immunocompromised are going to need a booster because they did not mount an initial good response to their first vaccines. But for kids with other illnesses and, particularly SLO or any other kind of complex stuff, you can still have mounted an appropriate response from your first set of vaccines. We do not know how long that lasts. Again, I'll say that a second time. We do not know how long that lasts. So it may be that we all are going to need boosters next year. We just don't know yet. Yeah. So do I have a preference for Pfizer or Moderna or J&J? I would say not J&J. That's the one that you only need one. And it was briefly extremely popular for that reason. But there have been more complications, especially rare blood clotting issues with the J&J. And the information that we are all seeing as physicians about the immunity and protection for children and so on, children couldn't get the J&J anyway. So there's really no data in children about that. So what I know the most about is Pfizer and Moderna. And in my mind, they're really pretty interchangeable. And if you can get the Moderna easily, get that one. If you can get the Pfizer easily, that's good. It doesn't really matter. A lot of people have asked, can you get Pfizer #1 and Moderna #2? That's been happening more and more because for a while there was vaccine shortages. And I know my husband is British and we have a lot of family in London. And for people over there, they were not even able to get their second shot in a timely way because they didn't have enough vaccines. So they're doing studies now to show that that's okay. But again, there's not a huge amount of information about that. So there's a question about typical siblings. Is it okay to keep your child with medical complexity at home, but still send your healthy child to school? And you're right, it is a red hot mess. It's a red hot mess everywhere. I try to talk to each family on an individual basis and just try to flesh out how vulnerable is the child. Do they have adrenal insufficiency? Do they have severe pulmonary or cardiac disease? Or do they have severe failure to thrive? And are they vulnerable to all kinds of infections no matter what? And do they have seizures? Having neurologic problems is another thing that makes you really higher risk for COVID complications. So kids with bad neurologic problems, especially seizures, have a higher risk. So, I sort of have to, I look at the child themselves who's vulnerable, and then everybody else at home. And then you can look and see what the risks are for your own community. There are websites in every different community all across the country that will tell you, how many new cases, how many hospitalizations, how many deaths, how many ICU admissions. And that is what everybody will go by to determine, can schools stay open? So if things get to the point this fall where the number of new cases has gone straight up and the hospital beds are filled and there's no place for patients to go, and the ICU beds are filled and the death rate is very high, then schools are going to be closed. Okay. And it may be different from place to place, depending on where you live. Right now, the southern states are bad. Florida, is filling up with pediatric beds and doesn't have a lot of open beds. Last year when we shut down, there were no beds on the adult side at all. We were taking adult patients into our pediatric ICU. All surgery, elective surgery was canceled. We couldn't see patients in person. And we're having conversations now about how much do we need to step back and go back because of how contagious this is. Because at one point, even when we opened up again, we were seeing patients, everybody got their temperature taken when they walked in the door, including doctors and patients. And we had to fill out this ridiculous, annoying questionnaire about whether you had any symptoms or not. And they screened your questionnaire as you walked in the door. If you had a single symptom, they sent you home. And, for patients and doctors, they were screening everybody. We're not doing that anymore. They've put all the computers back in the rooms. They put all the chairs back. So we're sitting very close to everybody again. For a while we were eating in our workroom with no masks on, and everybody, talking to everybody else with no masks on. As of last week, we now can't do that anymore. The only place we can take our mask off is in our own office by ourselves. So things are in flux, and which way they're going to go, I don't know. Yeah. So, let's see. Is there a greater risk for a mildly affected child who has type 1 diabetes? Yes. So there are certain chronic conditions that give an increased vulnerability. And that data is from the adult population. I think we know less about that in children, but in adults, things like diabetes, hypertension, heart disease, the sort of typical adult chronic problems, those were the people who got the sickest and who died of COVID early on. So we think that those chronic problems confer an increased risk, but that there's not great data in pediatric patients yet. Are physicians seeing folks having trouble handling regular common illnesses after having COVID? Gretchen, that is a great question. I'm really glad you asked that one. Yes. So what happens is if you've gotten COVID before, your lungs are not going to be normal afterwards for a long time. And even if you feel better and your cough is better, there's still been some chronic damage that has happened to your lungs from COVID. And so if you then get the next virus that hits your respiratory tract, then you're going to be more vulnerable to getting sicker with that next virus, whether it's influenza or paraflu or RSV or whatever it is. So we are starting to see patients who are being admitted to the hospital with some other virus who are very, very sick because there was damage to their lungs from their prior COVID infection. And again, I think that is going to take more time for us to better understand it. The only encouraging thing I can say about this is we know now how to treat a really sick patient with COVID. We didn't know in March of 2020 or April of 2020. We just didn't know. And so we know now what works and what doesn't work. Don't drink bleach. Don't take hydroxychloroquine. It ain't going to do you no good. But we know steroids can help. We can take care of our patients now. So if you do get sick and you're in the hospital, you have a better chance of recovering, being able to be discharged than you did in March or April or May of 2020 than you do in August of 2021. So we learned a lot, and we're better at it than we were before. But it's still a pretty new illness, right? It's a pretty new illness when you think that in this country, things really shut down in March of 2020, it was just not even quite a year and a half ago. So depending on which state you live in, and I want to not talk politics here, and which governors know how to follow science and which don't. I live in Colorado, and our governor went to Princeton, which is where I graduated from. So I know he's got some good marbles up there, and he follows science. It's not the truth for every state, but so no matter where you live, though, some schools are making masks mandatory and others are not. Some school systems are mandating teachers get vaccinated and others are not. So, for kids who are in a special ed class, and those classes are smaller size and it's easier to contain things in a smaller size classroom and to have distancing of the students and to mandate that every teacher in a special ed class with a very vulnerable child is vaccinated and wears a mask. You just have to decide what it looks like for your child where you live. You also have to follow the numbers. So if there's a huge number of cases wherever you live, or the beds are all full at the hospital, don't send your kid to school. It's too risky. It's too risky. What will it take for COVID to go away? I think you all know what I'm going to say, having heard me talk for the past 50 minutes or so. Get vaccinated. Until everybody is vaccinated, this will not go away. Make everybody in your family get vaccinated. It's what I'm saying to every single one of my parents who have vaccine hesitancy about getting this COVID. So I talk about their fears. I talk about what they're worried about. I talk about what old Uncle Joe told them that he heard or saw on the internet or whatever. And I try to give them the science and true data and let them make decisions. Everybody wants the best for their child. My kid, my choice, or my body, my choice. In my mind, that's a lot of what comes out of the back end of a male cow, because your kid is not living in a bubble. There are other people who are vulnerable all around your child at school, and just because you're making a decision, it can impact everybody else, not just you and your family and your kid. So I think I've become a little less patient than I used to be 20 years ago. I don't know. But I just am trying to protect my vulnerable families and so on. I have a few minutes left. Gretchen asked me to give you an update on what is happening with research for Smith-Lemli-Opitz and the project that I've been involved with here, still ongoing. I'll just take a second to do that, then be happy to answer any more questions people have. So there's been a new study. There have been 2 sites for this here in Colorado and with Bill Rizzo in Omaha, Nebraska. And this was a very teeny tiny small pilot study using a medication called cholic acid, which is a bile acid. I used cholic acid back in the 1990s in my patients with Smith-Lemli-Opitz in Boston, where I was practicing at the time. I think many of you know that I was one of the initial people who discovered the cholesterol metabolic error in patients with Smith-Lemli-Opitz, and I had very, very severe patients who had very low cholesterol levels. And if your cholesterol level is really low, not only can you not make cortisol, which we've talked about, but you can't make bile acids. Bile acids are compounds in your gut that you need to absorb nutrients. They're made from cholesterol in the liver. So if your cholesterol is super low, you can't make bile acids, and then you can't absorb nutrients in the normal way, particularly fats. So I gave cholic acid and several other bile acids in the early to mid 1990s to my patients with SLO with really low cholesterol levels. And it seemed to make a huge difference. They were able to absorb the cholesterol medicine I was giving them. So their cholesterol levels went up, their precursor levels went down, their liver function improved, and they were healthier and they gained weight better. The company that made the cholic acid thought it was really expensive to make it, didn't realize that it helped people, and there were people taking it, and they stopped manufacturing it. And for almost 25 years, there was no cholic acid. That even if I wanted to prescribe it, I couldn't, it wasn't being made. And then a new company bought out the rights to make it, and they listed Smith-Lemli-Opitz as one of the disorders for which they thought it would work. And they contacted me and they said, would you be interested in giving it? And I said, heck yeah. So back in 2018 is when we first started to try to go through all the forms and permissions and the regulatory steps that one needs to do to give what is now considered a sort of new medicine to patients. And so we did that. We got approval from the NIH. We got funding through the STARE consortium to give cholic acid. And then COVID happened. So everything came screeching to a halt, and I couldn't enroll any patients in the study for a long, long time. So we just reactivated and started enrolling patients in April of this past year. And also as the restrictions for travel became lifted so that people could either come here or see Bill Rizzo in Nebraska, we were able to get people to come because of COVID and the difficulties with travel and everything else. We cut back down the number of patients that were hoping to enroll in this project, but we were successful in enrolling 12 patients, which was our goal. So by the end of May, we had enrolled our 12 patients in this study. And what it looks like is that patients need to travel to the site where they enrolled twice. So on enrollment, which was in April or May, and then come back 2 months later. So it's a 2-month trial. And then we did some labs locally to make sure that some safety labs looked good so that the cholic acid can impact liver function. We were making sure there were no problems with that. And then 1 month after you stop the cholic acid, which for some patients will be September, we're going to get labs again one more time to show that there's no long-lasting effects of taking it. Sorry, so very small study. We're just starting to get the data back on the first patients who were enrolled, the earliest, and they look very promising. I think the cholic acid has been well tolerated, has not caused any severe liver problems in any of the patients so far. And my hope is that once we finish analyzing this data, that I will be able to talk the company into giving a reduced rate for giving cholic acid to my patients who need it. So the patients who need it the most are patients with severe disease who have really low cholesterol levels. If you're able to eat enough to get your cholesterol well up over 100, you probably need it less than if your cholesterol is well below 100. So we are very, very grateful. We've been in discussion with Gretchen and the board because the funding for this study runs out the end of this month, the end of August. But we need some extra money to pay for the tests that need to be done in September to show, that last month of tests. And things were a little slowed down. You've all noticed that the mail goes really slowly these days, right? So to get this special cholic acid medicine shipped to us by the drug company, there were some delays in that. So even patients, the last patients that I enrolled that last week of May, we didn't have enough cholic acid to even start the medicine until like the middle of June. And then 2 months after that is the middle of August, and 1 month after that is the middle of September. So there's this group of patients that I still need support to get their labs on. So I'm very grateful to the SLOs Foundation for giving us a small amount of funding to finish this study so that we can have all the data that we need to show that giving cholic acid is safe and effective in this small pilot project, with the hope of being able to use it again like I did back in the 90s for my patients. And so that's where that stands. And so there's a question from Gretchen, and will I study the benefits of cholic acid for patients who have a relatively normal cholesterol level? So I think that's a study that's worth doing. Cholic acid is very hard to manufacture, and therefore it's extremely expensive. So I think I would like to use it first in patients who really truly need it, because their cholesterol levels are very low and they can't absorb what I'm trying to give them. I think we had set a cutoff of 125 milligrams per deciliter for cholesterol level. And if your level came higher than that, I couldn't complete the study and give your child cholic acid, because we had to be really strict with the criteria. When you're doing a study with the NIH, they cross every T and dot every I, and so you just have to really follow the rules. So that's why there were a couple of patients I tried to enroll 10 patients altogether, but 2 were ineligible because their cholesterols were just a little bit too high. But for patients that I did treat, I tried to pick patients with lower cholesterol so I would see more of a benefit. And the way we made the criteria was for kids who were 2 years of age and older. So because young children just need to be followed very, very, very closely and more frequently, because they grow, their weights change and everything. And I was worried that with travel restrictions from COVID, I wouldn't be able to see little babies as often as I would need to. And so, but my hope is that it's really the little babies, the birth to 2-year-olds who would benefit the most from this if they have really low cholesterol levels. And those are the ones that I want to look at next when COVID restrictions allow. And God knows when that will be. And she hasn't told me yet, so I don't know. Let's see, I'm just looking at, and yes, I did, Nicole, get those levels, but by then it was too late. And when I say really low, so there's a whole spectrum of severity in SLOs. So if your cholesterol is vanishingly low, like less than 20, many of those patients are not able to survive. And so there's a high risk of miscarriage even before the child is born. And then there's a high rate of death during early infancy for children whose levels are 30 or less is in my mind what I think of as really, really severe, because then your cholesterol level does not allow you to do anything. You need cholesterol for every single cell in your body to stabilize cell membranes. And that is your blood cells, your skin cells, your GI tract cells, your neurons, the back of your eye, every single cell, especially ones that are rapidly multiplying. You need cholesterol for all of those cells. So if your cholesterol is very low and you're very severe, you just might not be able to survive. For people who have higher cholesterols and in whom I can get the cholesterol levels up, they do better. My goal is to get people to over 100. That's my goal with treatment, and to lower the precursors, which do bad things. If you don't have enough bile acids, it's hard to get that cholesterol level up. So that's why I'm going down this road. Okay, so we're at time. If people have other really burning or personal questions, I'd be happy to look at emails from anybody. And I think you can get my email from Gretchen or Andy or Karen or whatever. If you have a really concerning situation, I'm happy to answer emails. And it's been my pleasure to talk to y'all today. Hope everybody stays safe and healthy.
Thank you. We are so grateful for your time today and for the expert information and wisdom that you've shared with this community and that others will get to see in the video. Before we go, I just wanted to comment on a point that Angie had made about how fun it is to see some faces that we might associate with names on Facebook and in other forums, and also to see some of the kids moving here in all of their glory, coming in and out of the frames. So the foundation will look into having occasional coffees and get-togethers without agendas so that we can just get caught up with one another. But we really appreciate the time of Dr. Ellen Elias today to give us some more guidance during this difficult time for all of us. So thank you so much, Dr. Elias.
You're most welcome.
Thank you, Dr. Elias and Andy, for letting us hijack your Zoom.
Absolutely. And thanks to Kate and Gretchen who organized all of this. And we will see you at our next event.
Thank you.
Okay.
Can I say a quick thank you to everybody for supporting the foundation monetarily? Not only did Ellen reference the different grants that we're able to do for the medical advisory board specialists that we have on board, but other grants for researchers who submit them, all the time. So your support of the foundation is very instrumental in making things like this session, a different webinar series, and the conferences, which we hope will start again, hopefully soon in the future. So thank you to everybody.
Thank you, Gretchen.
Okay, you're welcome. Bye, everybody.
Bye.